Hello, everyone, and welcome to our module on asthma and bronchiectasis. Let's start by talking about asthma, which is a pulmonary condition caused by reversible bronchoconstriction. So, what happens in people who have asthma is they develop episodes where their bronchioles constrict, and this leads to airway obstruction and all the clinical features you can see in obstructive lung disease. But importantly, the episodes are reversible, and after they pass, patients can feel well in between episodes. Usually, what triggers the episodes of asthma is an allergic stimulus, and so asthma is considered an example of a type 1 hypersensitivity reaction. Basically, people affected by asthma have airways that are hyper-responsive and overreact to certain triggers. Asthma is common in children. You'll see a lot of it on your pediatrics rotation. Some of these children outgrow asthma when they become adults, but others do not. And because asthma is an allergic condition, it's often associated with other allergic or atopic conditions. So, children who have asthma, not only do their airways overreact, but they can have overreaction of other parts of the body. So, children with asthma often also have rhinitis or eczema or food allergies, and many of them come from families where there's a family history of various allergic reactions. So, what are some of the triggers for these episodes of asthma? One of the big ones is an upper respiratory infection. So, many children with asthma, when they get a common cold that they catch from other children at school, that will trigger an episode of asthma. There are also lots of different allergens that have been associated with episodes of asthma. These include some of the things I've listed here, like animal dander and dust mites and mold and pollens and even certain foods, but there are many, many others if you want to read about this. You can also sometimes see patients who have asthma triggered by stress or exercise or exposure to cold air. And then finally, there's a rare subset of patients who have asthma triggered by aspirin. So let's talk about that now. So AERD stands for aspirin exacerbated respiratory disease. And people who have this condition have asthma that can be triggered by aspirin. They also have chronic rhinosinusitis, so they can have inflammation of the sinuses and runny noses. And they also often develop polyps in the nose. This is called nasal polyposis. So these three things here are called Samter's triad. And this occurs in patients with AERD who have chronic asthma and also rhinosinusitis symptoms. And importantly, they have acute exacerbations of their asthma after ingesting aspirin or other NSAIDs. So why does this happen? Well, it's because people who have AERD have dysregulation of arachidonic acid metabolism, and it's very high yield to understand this. And aspirin and other NSAIDs disrupt arachidonic acid metabolism even further than the baseline dysregulation that these patients have. In particular, it's been well described in the literature that when these patients ingest aspirin or NSAIDs, they overproduce leukotrienes. Basically, aspirin leads to increased production of leukotrienes in these individuals, and that's what can trigger an asthma episode in patients who have AERD. And in another video, I talk about the way that we treat asthma. There are a number of different drug classes that are used, but for people who have AERD, the ideal treatment is a leukotriene receptor antagonist drug, drugs like montelukast and zafirlukast. Both of these block leukotriene receptors, and that's the problem, excess leukotriene activation of receptors in AERD. So what are the symptoms of asthma? Well, as I said before, the symptoms are episodic, so patients can be completely normal between episodes. When they do have episodes of asthma, they will develop dyspnea, they can develop wheezing from bronchoconstriction, and also cough. And if it's bad enough, patients can develop hypoxia during an episode. Another classic finding during an episode is a prolonged expiratory phase. Anytime there's constriction of the airways, it's hard to get air out of the lungs, and if people breathe slowly for a longer period of time in the expiratory phase, that improves the amount of air that they're able to get out. So patients with any form of obstruction in their lungs, including asthma, often develop a prolonged expiratory phase. This is sometimes called a decreased I to E ratio. The I to E ratio is the time spent during inspiration divided by the time spent during expiration. And this ratio goes down because the expiratory phase is prolonged in patients during an episode of asthma. This is a peak flow meter shown on the slide here. It's a tool that can be used for patients with asthma to determine if they're having an episode. During an episode, if they blow as hard as they can into this device, it will record a reduced peak flow compared to their baseline. That's one of the ways patients can know they're developing an asthma episode. Patients with asthma can produce mucus, and this can potentially plug up the airways. If that plugs up the airways, you will have areas of the lung that are not getting any ventilation, but they can have blood flow. And this can lead to shunting, and that's one of the reasons that hypoxia and hypoxemia can develop during episodes of asthma. And then it's rare, but you can die from asthma. This is caused by status asthmaticus, which basically means a prolonged asthma episode that does not resolve even with drug therapy. This is called status asthmaticus, and it's the way that people sometimes rarely die from this condition. So, asthma is usually diagnosed based on the history and physical exam. If it occurs in a child who has a history of other atopic diseases and they report wheezing and shortness of breath that comes and goes in episodes, that's usually how the diagnosis of asthma is made. The physical exam is helpful during an episode, but you should be aware that it can be normal outside of an episode. So don't get fooled by this in a board question. A patient who has asthma but is not in the midst of an episode can have a normal physical exam at that time and even normal spirometry results. If there's confusion about the diagnosis, there is a test that can be done. It's called the methacholine challenge test. Methacholine is a muscarinic agonist that causes bronchoconstriction. And the way you do this test is you administer increasing amounts of nebulized methacholine, and you ask the patient to perform spirometry after each dose. And you look for the dose at which the FEV1 starts to fall significantly from bronchoconstriction. If that dose is very low, it's considered a positive test, and the patient likely has asthma. So on the slide here is an example of the kind of results you could see from a methacholine challenge. Along the x-axis is the inhalation units of methacholine, and along the y-axis is the FEV1. You can see that in a normal patient, even when you get up here into high doses, they still aren't dropping their FEV1. But in an abnormal result, like you'd see in a person with asthma at these lower dosages down here, you start to see the FEV1 fall, and that's because these patients have airways that are hypersensitive and they're overreacting to the methacholine. Let's talk a little bit about the pathology of asthma. So if you look at this cartoon on the slide here, this is what healthy airways look like. These are open bronchioles where air can easily move through them. Over here is what you can see in a patient who has severe asthma with multiple recurrent episodes. So they can develop smooth muscle hypertrophy around the bronchioles. This can lead to tight muscles. That's what's shown here. And then all the inflammation in the airways can lead to swelling and the production of mucus. And as you can imagine from looking at this cartoon, this creates an obstruction to airflow. That's what causes the wheezing and the dyspnea. If you examine the sputum of patients who are having an asthma exacerbation, there are a couple of classic findings. This isn't something that we routinely do, but hundreds of years ago when asthma was first defined, pathologists used to look at the sputum and there were two key findings. The first was the presence of Kirschmann spirals. That's what's shown here. This spiral is actually a cast or a mold of the bronchioles. Basically, all those inflammatory cells and mucus are forming a cast of the bronchiole, and that's getting coughed up when the patient produces sputum. And then over here on the right is a picture of Charcot-Leyden crystals. That's what these are right here. These are remnants of the breakdown of eosinophils. You can actually see these in any allergic lung condition. So they're seen in asthma, but in other eosinophilic allergic type lung conditions, you can also see Charcot-Leyden crystals. In the cardiology section in the video on pericardial disease, I talk about pulsus paradoxus. It is a classic finding in patients who have cardiac tamponade, but you should be aware that it does sometimes occur outside of cardiac tamponade, and the most frequent non-cardiac causes pulsus paradoxus are asthma and COPD. So pulsus paradoxus refers to a decrease in blood pressure during inspiration. We all have this, but it's relatively small, just a few millimeters of a decrease in blood pressure during inspiration. But in certain pathologic states, there's a greater decrease than normal, and this is called pulsus paradoxus. The classic situation in which this occurs is in a pericardial effusion, but I just want to point out here that you can also find a pulsus paradoxus in someone who has advanced asthma or COPD. This is not something we usually check for clinically. It's more of a quirk you just have to know for your board exams. Okay, so that's asthma. So now let's talk about bronchiectasis. So bronchiectasis refers to permanent airway dilation, and it's caused by chronic recurrent airway inflammation. Basically, anyone who has long-standing, episodic, or chronic inflammation of the airways can eventually develop dilation. You can see this in this picture over here. This is a normal airway here. And in bronchiectasis here, we have these big dilated airways filled with mucus. That's the result of chronic recurrent inflammation. In this condition, the large airways become dilated. We'll see some pictures of this in a minute. But what you need to understand is all this mucus production that you see over here, that can cause the bronchioles to become plugged up. It can cause their walls to become thickened, and this leads to obstruction. So this is somewhat counterintuitive. You might think that when the airways become big and dilated, that there would be easier airflow and less obstruction, but that's not the case. And it's because of what happens in the small and medium-sized bronchioles. those walls become filled with mucus and thickened, and that leads to features of obstructive lung disease. So on the left here is a gross specimen of a lung from a patient who has bronchiectasis. You can see this airway down here, which is being pulled apart, is dilated. And then over on the right is a CT scan from someone who has bronchiectasis. Hopefully you can easily appreciate that these are enormous airways here that I'm circling with my pen. These are evidence of bronchiectasis. Let's talk about the clinical features of bronchiectasis. So first of all, these patients often have recurrent infections. Those dilated airways are coated with mucus, and that becomes a breeding ground for bacteria. The mucus can cause coughing, and then it can cause patients to produce sputum, and classically they produce excessive foul-smelling sputum. Because the mucus pools and festers in those large dilated airways, it's often foul-smelling when they cough it up. The dilated airways can damage blood vessels, and this can lead to hemoptysis. And then bronchiectasis can cause pulmonary hypertension and cor pulmonale. Also, because it's associated with chronic inflammation, it can lead to secondary amyloidosis. And I talk about amyloidosis in detail in another video. So what are some of the etiologies or the causes of bronchiectasis? Well, first of all, if there's a focal obstruction, like a tumor that's causing obstruction of one of the bronchi, or a small foreign body that's been aspirated and is lodged in an airway, this can cause focal bronchiectasis in the affected airway. This won't be diffuse all over the lung like that CT scan we saw a few slides ago. It'll only be in one area where there's an obstruction. Patients who smoke can develop bronchiectasis in addition to COPD. Cystic fibrosis is a classic etiology of bronchiectasis. Those patients have chronic lung problems, and that can lead to dilation of the airways. And then these last two things here we'll talk about in the remainder of this video. The first one is Cartaginer syndrome. The second one is allergic bronchopulmonary aspergillosis. In the cell biology section, in the video on the cytoskeleton, I talk about a rare condition called primary ciliary dyskinesia. In this condition, the cilia are unable to beat or beat normally, or they are completely absent. This is a genetic condition. It's inherited usually in an autosomal recessive manner, and it involves gene mutations in genes that code for a protein called dynin. And these gene mutations cause the dynin protein to either have abnormal structure or abnormal formation. So dynin is a motor protein that creates movement. It's a very important part of the cilia in the epithelial lining of the lungs. And so in primary ciliary dyskinesia, because the dynin is not normal, that leads to abnormal cilia, and that's what leads to this condition. And when primary ciliary dyskinesia is accompanied by situs inversus, which I'll talk about in a second, we call that Cartaginer syndrome. So Cartaginer syndrome is a variant of primary ciliary dyskinesia. And in Cartaginer syndrome, first of all, patients develop bronchiectasis, and this is because their cilia are abnormal because of abnormal dynin, and therefore they have chronic inflammation in the lungs, and that's what leads to bronchiectasis. These patients can also develop chronic sinusitis, once again, because of abnormal cilia and inability to clear bacteria from the airways. In males, there's often infertility, and that's because dynin is very important for motility of sperm. And then lastly, dynin is important for the normal orientation of the organs in the chest. So patients with Cartaginer syndrome have situs inversus, meaning that the heart is on the wrong side of the chest. And so if you look at these images on the screen, they all show situs inversus. So here's the heart in this patient here. The heart should be on the left side over here, but instead it's pointing over here to the right. That's situs inversus. This is a CT scan here at the top. This is the left side. This is the right side. The heart should be mostly over here, but instead it's over here on the right side. You've got the same thing in these bottom two CT scans. So these are the kind of findings that on X-ray and CT are fairly easy to recognize, the heart being on the wrong side of the chest. So make sure you're able to see that. And when you see that together with chronic inflammation in the lungs and bronchiectasis, that's Cartaginer syndrome. It's a ciliary motility problem related to the protein dynin. So this is a very rare condition. You're unlikely to see it clinically, but the classic case you want to be familiar with for your board exams is going to be a child who inherited this condition. The child will have recurrent sinus and ear infections and a chronic cough. They may show you bronchiectasis on a chest CT scan. They may show you pulmonary function testing results, and they will show obstruction because remember what we said, bronchiectasis leads to airway obstruction. And then lastly, there will be situs inversus. And the question often asks about the abnormal cilia or the dynin protein. Now let's talk about another cause of bronchiectasis, and that's allergic bronchopulmonary aspergillosis. This is a hypersensitivity, meaning an allergic reaction to the fungus Aspergillus. What happens in patients with this condition is their lungs become colonized with a form of aspergillus called Aspergillus fumigatus. This is a low virulence fungus, usually only infects the lungs of patients who are immunocompromised in some way or have debilitated lungs for some reason. So because of this, allergic bronchopulmonary aspergillosis usually occurs in patients who either have significant asthma or who have cystic fibrosis. In the basic science literature, people have studied the lungs of patients who have ABPA, and these are some of the things they've found here that may come up in a board question. So first of all, these patients have an increase in CD4 positive T cells. These T cells produce interleukins. They also lead to the generation of IgE antibodies that you can detect in the serum. And then lastly, this is an allergic reaction. So just like many allergic reactions, it's associated with eosinophilia, meaning an eosinophil count in the peripheral blood that's greater than 500. So the classic case of ABPA that you want to be familiar with is going to be a case involving a patient with asthma or cystic fibrosis who has recurrent episodes of cough, fever, and malaise. These are the recurrent infections associated with bronchiectasis. They may also cough up mucus plugs or have hemoptysis. These are also things that go with bronchiectasis. They will most likely describe in the peripheral blood eosinophilia and a high IgE level. These are two criteria often used to make the diagnosis. And if they describe imaging, there may be bronchiectasis on imaging. And this is another CT scan here of a patient with dilated airways from bronchiectasis. And then they may also tell you pulmonary function testing results, and those will show evidence of obstruction, which I describe in detail in other videos. The diagnosis and treatment are low yield, but just so you're aware, the diagnosis can be difficult to make. Usually it's only made in patients who have asthma or cystic fibrosis who also have eosinophilia and a high IgE level. And then the treatment is with steroids to suppress inflammation and itraconazole to try and eliminate the fungus. So I'll finish with this one slide, which has a summary of how you can approach problems involving lung diseases. So remember that at the first and second year med student level, they're going to test you on the basics. So they're going to want you to be able to recognize restrictive versus obstructive lung disease patterns based on pulmonary function testing results. So make sure that you can do that. Once you see that the patient has obstructive disease, there's basically four conditions you want to think about. The first two are chronic bronchitis and emphysema, which are collectively called COPD. Most emphysema is associated with smoking, but there is a rare cause that's alpha-1 antitrypsin deficiency, and I talk about this in the video on COPD. If they describe a patient who has obstructive PFTs, but has intermittent episodes where they're short of breath and then come completely back to normal, that's probably talking about asthma. And then lastly, the other cause of obstructive disease you should know is bronchiectasis, and that has all these causes down here. But once you recognize they're describing an obstructive patient who has bronchiectasis, then hopefully you can look through the causes like this and know what they're asking for in the question. And that concludes our module on asthma and bronchiectasis.